Welcome to the deep dive. Today we're opening up a really fascinating stack of sources.
Yeah, we really are.
It's an authoritative medical guide detailing the systematic ENT clinical examination. So ear, nose, and throat.
Right.
But, and this is key, we are looking at the FRCS level materials.
Which is the Fellowship of the Royal Colleges of Surgeons.
Exactly. So we are completely bypassing, basic first aid here. We're going straight to the manual that's used to train advanced surgical candidates.
The real high level stuff.
Yeah. And our mission today is to decode the secret language of physical exams, turning you into an insider on how top-tier medical specialists act as, well, basically biological detectives.
I like that, biological detective.
Because before they ever, order a CT scan or an MRI, these surgeons rely almost entirely on their own senses. Think of it like taking your car to a master mechanic.
Right, a really experienced one.
If the engine is rattling, they don't just immediately grab a blowtorch and cut the hood open.
No, of course not.
They observe the vibrations, they listen to the idle, check the belts. It's a highly deliberate, structured process for troubleshooting a complex engine, except in this case, the engine is the human head and neck.
Yeah, that's a perfect way to look at it.
Okay, let's unpack this. Because the foundational framework of this entire guide, like the bedrock of how a surgeon approaches you in the exam room, rests on a 4-step standard operating procedure. Look, listen, feel, move.
What's fascinating here is why that 4-step sequence, look, listen, feel, move, or LLFM, is so brilliant in its simplicity.
Right.
When a doctor is dealing with something as densely packed and frankly vital as the human airway or the neck, the psychological temptation is to just rush in and poke directly at the obvious problem.
Oh, absolutely. Like you see a lump, you want to touch the lump.
Exactly. But this framework strictly prevents doctors from jumping to premature conclusions. It forces a highly disciplined progression.
So you have to start purely with observation.
Right. Looking and listening alters absolutely nothing about the patient's physical state. You are just gathering raw, unfiltered data.
Just standing back and taking it in.
Yep. And only after that mental map is built does the surgeon transition into physical interaction. So, feeling the tissue and finally moving the structures to test the mechanical function.
I mean, by the time a surgeon actually touches a patient's neck, they've already gathered a massive amount of diagnostic data just by watching them breathe and listening to the cadence of their speech.
Yeah, it ensures subtle clues aren't accidentally masked by an aggressive physical exam.
Right. And we see this in action immediately when the guide tackles what we can call the sensory detectives, the ears, the nose, and the eyes.
The outside approach.
Exactly. Before doctors inspect the internal plumbing of the throat, they start from the outside, testing the acoustic chamber of the skull. And they use some incredibly clever, surprisingly low-tech tricks to do it.
Really low tech, yeah.
Let's look at the ears first. Testing hearing at this level isn't just, asking if someone can hear a whisper from across the room.
No, they bring out the tuning forks.
Yeah, the tuning forks, to perform tests known as Rinn and Weber.
And the goal there is to separate mechanical failures from electrical wiring failures.
Which is such a wild concept.
That distinction is crucial though. A mechanical failure or conductive hearing loss means there is a physical roadblock, like fluid in the middle ear or a damaged eardrum.
So the sound waves literally cannot physically travel through the ear canal.
Exactly. But an electrical failure, or sensory neural hearing loss, means the canal is perfectly clear, but the acoustic nerve that sends the signal to the brain is damaged.
So how do you figure out which one is happening?
Well, the surgeon uses the skull itself as a shortcut.
Right.
They strike a tuning fork and place the vibrating metal base directly onto the mastoid bone, which is that hard lump right behind your ear.
Because bone is an excellent conductor of sound.
Yeah, really good.
The vibration travels directly through the skull bone into the inner ear, completely bypassing the outer ear canal and the eardrum.
Right. And once the patient says they can no longer hear the vibration through the bone, the doctor instantly moves the still vibrating prongs next to the open ear canal to test air conduction.
And normally air conduction is more efficient, right? So the patient should hear the sound again.
Yes, normally.
But if they can't, if they heard it through the bone perfectly fine but hear nothing when it's just vibrating in the air, the surgeon instantly knows the nerve is healthy, but there is a physical blockage in the canal.
They've isolated the failure point using nothing but pure physics.
It's amazing. And that mechanical deduction applies right across the face. Like when checking the nose, they do something called Cottle's test.
Oh yeah, Cottle's test.
The doctor places their fingers on your cheeks and gently pulls the skin laterally out toward your ears and then asks you to breathe.
Mechanically, if pulling the cheek improves your airflow, it tells the surgeon that your nasal valve, which is the narrowest part of your nasal airway, is structurally collapsing every time you inhale.
So it's a structural failure, not just, seasonal congestion.
Exactly, separates anatomy from inflammation.
Right.
And if they suspect an infection deeper inside the facial bones, they utilize transillumination.
This one blew my mind.
Yeah, so a healthy sinus cavity is hollow and filled with air. If you turn off the room lights and press a highly focused pen light firmly under the cheekbone or just above the eyebrow, that light will actually scatter through the air cavity.
Wow.
And it glows faintly through the skin or the roof of the patient's mouth.
It is literally like shining a flashlight into a Halloween pumpkin to see if it's hollow.
That's a great analogy.
But if the pumpkin is completely packed with mud, or in this case, if the sinus is packed with fluid or dense tissue, the light doesn't shine through. It remains completely opaque.
Right, it's a beautifully simple way to look inside the skull without using any radiation.
Yeah, no x-rays needed. But speaking of looking, the guide inevitably moves to inspecting the eyes. And I have to push back on one specific instruction here.
Oh.
Because it makes total sense for an ENT to check if an eyelid is drooping due to a nerve issue. But the manual explicitly tells the doctor to listen to the eyes.
Ah, yes.
Wait, how and why does the doctor listen to an eyeball? That sounds less like advanced medicine, more like a parlor trick.
I know, it completely defies intuition until you consider the fluid dynamics of the vascular system.
Okay, lay it on me.
The doctor will actually place the bell of their stethoscope gently over the patient's closed eyelid to listen for what is called an orbital bruit.
A brute?
Yeah, a bruit is the medical term for the sound of turbulent blood flow. Imagine a kink in a garden hose. The water suddenly rushes and hisses.
Right, because of the pressure.
Exactly. In the case of severe head trauma, a patient can develop a carotid cavernous fistula.
Which is what, exactly?
That's an abnormal direct connection between a high-pressure artery and a low-pressure vein located right behind the eye.
Oh, wow. So the high-pressure arterial blood is violently rushing into a venous system that isn't built to handle that kind of flow.
Yes.
Creating a literal rushing noise.
And because the skull acts as a highly effective acoustic chamber, the patient rarely comes in complaining about their eye.
Really?
Yeah, they usually come to the clinic complaining of severe pulsatile tinnitus.
Which is like a loud, rhythmic, rushing sound in their ear that beats in time with their heart.
Exactly. The ringing ear is just a symptom. The stethoscope on the eyelid reveals the busted pipe behind the eye that's causing it all.
That perfectly illustrates how you just cannot isolate these structures. The ear, the nose, the eye, they share the same structural housing.
Fair enough so.
Which makes the next phase of the exam so critical. Once the external sensors are tested, the physical exam moves inward and downward into the oral cavity and the airway.
Right.
This is where doctors evaluate the complex intersection of mechanical plumbing and neurological wiring.
Because multiple cranial nerves converge in the mouth and throat to control these dynamic lysosome functions.
Like swallowing, speaking, and protecting the lungs from food.
Yeah, and evaluating those nerves requires live dynamic testing.
The classic say-ah test is the perfect example of this.
It really is. Most people assume the doctor's just trying to lower the tongue to get a better view of the tonsils.
Right, just getting it out of the way.
And while it does provide a clearer line of sight, the test is actually evaluating cranial nerves 9 and 10.
Okay, so when a healthy person says, ah, the soft palate at the roof of the mouth should elevate symmetrically, pulling straight up.
Right.
And the uvula, that little punching bag hanging in the back of your throat, should stay perfectly centered in the midline.
Because both the left and right cranial nerves are firing equally, playing a perfect game of tug of war with the tissue.
But if there's a nerve palsy on one side,
That side goes limp.
oh.
The healthy side overpowers it, and the uvula gets pulled off center, pointing toward the working side.
So just by watching that tiny movement, the surgeon knows if the electrical wiring in the brainstem is compromised.
Exactly.
Yeah.
But they also have to rule out mechanical blockages.
Right, because it could be something physical.
Yeah. If a patient have a massive peritonsillar abscess, a severe infection, the physical swelling will violently push the uvula off to the side, completely independent of the nerves.
And determining the difference requires the doctor to be incredibly hands-on. The ENT exam is an intensely physical process involving bimanual palpation.
Bimanual meaning 2 hands.
Right. The guide describes the doctor placing a gloved finger inside your mouth completely under your tongue while using the fingers of their other hand on the outside of your chin, pressing facing upward.
They're trapping the tissue of the floor of the mouth between their two hands.
Feeling for hidden masses or salivary stones, which are literal calcified rocks that can block your spit glands.
Yeah, they're not fun.
And here's where it gets really interesting. To check the plumbing of those specific glands, surgeons do something called milking the ducts.
The human face has major saliva factories. The parotid gland sits right in front of the ear with a tiny tube called Stenson's duct, emptying into the cheek opposite your upper teeth.
Okay.
And the submandibular gland sits under the jaw, emptying through Wharton's duct, right under the base of the tongue.
So the doctor will actually massage the side of your face, or under your jaw, and watch inside your mouth to see if a clear drop of saliva flows out of those tiny duct openings.
Exactly.
If testing the cranial nerves with, say, is like checking the home's electrical breaker box, then milking the salivary glands is exactly like checking to see if the water pipes are clogged with mineral deposits.
That's spot on. You are verifying both the wiring and the plumbing in real time.
And that structural verification flows right down into the larynx, the voice box.
And here, listening becomes paramount again.
Because the doctor isn't focused on the words the patient is saying, right? They are listening to the mechanical friction of the engine.
Yeah, they listen for stridor, which is a harsh, high-pitched whistling sound during inhalation that screams of an upper airway obstruction. They also evaluate the texture of the voice. A husky, hoarse voice is a massive red flag.
Because hoarseness isn't always just a cold or a sore throat.
No, it's often not.
The recurrent laryngeal nerve, which controls the vocal cords, takes a bizarre anatomical detour.
It really does. It travels from the brain all the way down the neck, loops under the major blood vessels in the chest like the aorta, and then travels all the way back up to the voice box.
So because that wire is so long, a husky voice can be the very first symptom of a tumor pressing on that nerve deep inside the chest cavity.
Which highlights why visual confirmation is required.
Right.
They will have the patient sustain an E sound while looking down the throat with an angled mirror or a flexible scope.
Just to watch the vocal cords.
Yeah, they need to physically watch the vocal cords vibrate and snap together. If one cord is paralyzed and failing to close, the patient's airway is essentially unprotected.
Man. And this careful navigation of the airway leads us directly to the most dense, crowded real estate in the entire body. The neck.
Yeah.
You've got major blood vessels, the windpipe, the esophagus, the thyroid gland, and dozens of lymph node chains all packed into this tight, muscular cylinder.
It's incredibly complex.
A surgeon has to figure out exactly what a lump belongs to without relying on a scalpel. And the centerpiece of navigating this hidden landscape is the swallow test.
It is elegantly simple, relying entirely on understanding facial attachments.
So the doctor simply gives the patient a sip of water and observes the neck.
Right, if we connect this to the bigger picture, swallowing is a highly coordinated mechanical defense.
Okay.
The thyroid gland is enclosed in the pretracheal fascia, which is a tough sheath of connective tissue that binds the gland directly to the larynx and the windpipe.
So when you swallow, your larynx naturally has to pull upward to close off the windpipe so you don't choke on the water.
Exactly.
And because the thyroid gland is physically strapped to that windpipe, it has to hitch a ride and move up too.
It has no choice.
Therefore, if a patient has a mysterious lump in their lower neck and they swallow, and that lump aggressively moves up and down with their Adam's apple, the doctor instantly knows it is structurally attached to the trachea.
It's a thyroid issue.
It's just so logical.
Conversely, if the lump stays perfectly still during a swallow, it is not attached to the airway.
So what is it?
It is likely a swollen lymph node. And evaluating those nodes is a meticulous process. They're feeling from the base of the skull, down behind the ears, under the jaw, and all the way down to the collarbone.
Just palpating all of them?
Right, the doctor's assessing consistency. A soft, squishy node is often just a reactive infection.
But a rock hard node.
A rock-hard node that feels tethered to the underlying muscle is highly suspicious for malignancy.
Wow. But okay, with all these structures crammed together, how do they test for hidden vascular issues? Like the plumbing could be under immense pressure.
Oh, there's a provocative maneuver mentioned in the guide called Pemberton's sum.
Okay, how does that work?
The doctor asks the patient to raise both arms high above their head, touching the sides of their face, and to hold them there for a minute.
Okay, if I'm thinking about the fluid dynamics here, gravity is forcing all the blood from the elevated arms to drain rapidly back down into the chest.
Yes.
If the patient has a massive thyroid goiter or a tumor in the lower neck, that mass is acting like a cork in the top of the chest.
Exactly.
So when all that extra blood volume rushes down from the arms, it hits the bottleneck.
That is exactly the mechanism. The bottleneck prevents the venous blood from returning to the heart.
So what happens?
Within moments, the veins in the patient's neck will visibly bulge, and their face will turn red and congested. Wow. It is a powerful, low-tech way to prove a mass is compressing the major vascular pathways.
That is wild.
They will also apply the stethoscope directly over the thyroid gland itself.
Listening for that brood again, that hissing garden hose.
Yes, a healthy thyroid is silent. But in a condition like Graves' disease, where the thyroid is severely hyperactive, the metabolic demand is so high that the blood vessels dilate massively.
Right.
The blood flow to the tissue becomes a high-output torrent, creating a continuous rushing brute right over the gland.
So we have tuning forks vibrating through skulls, we have transilluminated pumpkin sinuses, we are milking salivary ducts, utilizing swallow tests to map fascial attachments, and raising arms to trigger blood pressure bottlenecks.
It's quite the list.
We've gathered an absolute mountain of physical data, but data is completely useless without processing engine.
Exactly.
The guide doesn't just list these tests, it explicitly introduces Bloom's taxonomy for clinical reasoning.
And this raises an important question. How does a surgeon actually synthesize these conflicting data points in real time?
Right, because having the data isn't the same as understanding it.
No, it's not. This is where the deep dive transitions from physical anatomy to the psychology of medical deduction. Bloom's taxonomy is a cognitive framework outlining how the brain evolves from basic recall to complex problem solving.
Right.
A novice relies on the first two levels, remember and understand. You remember that tenderness behind the ear suggests an infection.
But you must understand the mechanism.
Yes. You understand that if the pressure valve in the throat isn't working, it creates a vacuum, retracts the eardrum, and allows fluid to fester in the bone.
So you can't just memorize the symptom, you have to grasp the physics causing it.
Precisely. Then, the surgeon moves up the ladder to apply and analyze.
Okay.
You apply your knowledge by striking the tuning fork properly, but then you analyze the results in real time against the rest of the exam.
So you analyze the visual data from the swallow test, combining it with the tactile data of how rock hard the lump feels to categorize the exact nature of the mass.
Which brings the surgeon to the pinnacle of the taxon, evaluate and create.
Right.
If the exam reveals a patient has a husky voice, and the scope shows a paralyzed vocal cord, the surgeon has to evaluate the severity. They judge that this nerve palsy implies a hidden tumor deep in the chest, pressing on that recurrent laryngeal nerve.
Okay, let's unpack this. So what does this all mean? It means the final step, create, isn't about creating a physical object, right? It is formulating a comprehensive, custom-tailored patient management plan.
Yes, creating a pathway.
They create a pathway for targeted imaging and treatment based entirely on the clues they gathered with their own hands, eyes, and ears.
An FRCS level exam is not a routine checklist.
No, clearly not.
It is a live masterclass in real-time logical deduction. They are cycling through Bloom's taxonomy, constantly remembering anatomy, applying provocative tests, analyzing acoustic data, and creating a solution, all while casually chatting with you about your symptoms.
It represents the massive evolutionary leap from a medical student who memorizes textbook diagrams to a master surgeon who synthesizes multiple streams of sensory data to solve a highly complex human puzzle.
That's exactly it.
Well, to briefly recap the journey we've taken through this guide today, we started with the universal bedrock of look, listen, feel, move.
The foundation.
We explored the acoustic chamber of the skull, using transilluminated light and tuning forks to bypass the ear canal, and even stethoscopes to detect rushing fistulas behind the eye.
Yeah.
We navigated the complex plumbing of the mouth, testing cranial nerve tug of war with a simple say, and verifying fluid dynamics by milking salivary ducts.
Right.
We decoded the hidden structural anchors of the neck, using swallow tests and gravity to map out masses without a single incision.
And finally, we uncovered the cognitive engine of Bloom's taxonomy that powers a surgeon's reasoning.
Which leaves us with a final thought to mull over. We are entering an era where artificial intelligence and machine learning are being trained to diagnose diseases based on vast oceans of patient data.
Oh, absolutely.
These algorithms can undoubtedly look at high-resolution scans, and they can listen to audio recordings of coughing or speech patterns with incredible precision.
Better than a human sometimes.
But as we've learned today, true clinical mastery requires feeling the precise density of a lymph node, or physically milking a duct, or sensing the subtle resistance of a collapsed nasal valve.
That tactile feedback.
Exactly. Can a machine ever truly replicate the LLFM framework?
Right.
Or will the tactile intuition of an expert surgeon always be the ultimate diagnostic tool? Something to think about next time you're sitting on an exam table.